So let's move on to the second item with Dr. M.NGUYEN.
Thank you, Pierre-Grégoire. So today I have the pleasure to talk to you about the clinical reasoning with and without hemodynamic device. So it's in the context of hypotension in the operating room. So clinical reasoning is a daily process by which we link a symptom to a diagnosis. And when you're applying clinical reasoning to hypotension, here are the data you should have in mind. So you start with a low map pressure, let's say pathological low map pressure, so in the context of hypoperfusion. You apply the basic hemodynamic equation for map pressure, and you can find the determinant of map pressure. Those determinants have been combined to determine several kinds of shock, several types of shock. And so there are two frequent types of shock in the OR, which are distributive vasoplegia and hypovolemic shock. And there are two less frequent kinds of shock, which are cardiogenic shock and obstructive shock. And beyond each type of shock, you have, of course, different causes for the hypotension. So let's go at bedside with a 55-year-old man without relevant medical history planned for cilioscopic right colectomy. And let's say just after incision, the surgeon hit the spleen, so you have a massive bleeding and a major hypotension. So how do we reason in this situation? In this situation, the reasoning we apply is called pattern recognition reasoning. So basically, we see blood, we see hypotension, we say, oh, I know what this situation is. It's hemorrhagic shock, so that's an easy one. And that's probably the best kind of reasoning in this situation because it enables you to treat your patient early, thus to reduce organ suffering in your patients. Okay? So let's say now you're taking the same patient for the second look surgery, and 10 minutes after incision, he developed hypotension. So now, how do we reason in this situation? So the first is to apply this pattern recognition reasoning to eliminate the obvious. And so you apply your pattern recognition reasoning and you eliminate major bleeding, surgical compression that could enable venous return, impair venous return, sedation overdose, and severe bradycardia or arrhythmia that are obvious causes of hypotension. Let's say in this case, your patient does not have an obvious case of hypotension, so you are not able to make an easy diagnosis out of this one. So you need to switch to another kind of reasoning, which is called the hypothetico-deductive reasoning. And this is the kind of reasoning we've all been taught at med school. You start from the symptom. You generate a bunch of hypotheses, which are here the type of shock, and then you evaluate each hypothesis, and the more you determine which is the most probable diagnosis for your patients. So let's say your patient only has basic monitoring. So the minimal required by law when you're doing anesthesia. Here are the hemodynamic value you would get. And the first thing you need is to determine from this value which determinant of arterial pressure is impaired in order to diagnose the type of shock and thus to know what is happening in your patients. So among those values, what you can use is pulse pressure and the pulse pressure to heart rate ratio that reflects stroke volume, and diastolic arterial pressure is also daily used as a reflect of arterial load. But while using those values, you should keep in mind that although they are associated with the parameter, so here diastolic arterial pressure is associated with vascular tone, they are not a perfect reflection of this parameter, and this is the same for pulse pressure variation and stroke volume, and the pulse pressure to heart rate ratio and stroke volume, and thus you should be careful while interpreting these results. So here is one way to sort out the different type of shock, knowing the determinant of hypotension. And so you use your pulse pressure and your diastolic arterial pressure. And if you believe you have a high cardiac output and a low arterial load, you'll say you're facing a distributive shock. So here this is not the case because your pulse pressure is 20, so it's pretty low, and the diastolic arterial pressure is rather preserved. So you're not looking to a distributive shock, so you can move on to the next step, and you should determine your patient preload in order to know if you're facing the second most common kind of shocks, which is hypovolemia. So unfortunately, from those static parameters you have, you cannot determine your patient preload. And what I propose you to do, and what most of us do in this situation, is to perform a fluid challenge. But now you're confronted to a new challenge, and this challenge is how to detect that your patient is fluid responsive while you are not measuring the cardiac output. And this is a question that the author here tried to answer, and unfortunately, it is the same as for pulse pressure and diastolic arterial pressure. Although there are associations, there are indicators like the increase in map pressure or the increase in pulse pressure might be used as indicator. They are not the perfect indicator of an increase in cardiac output. So let's say you're looking to those indices and your patient is not preload responsive. So now the next step is to determine your patient inotropism in order to know if you're facing cardiogenic or obstructive shock. And with your basic monitoring, you are unable to determine the inotropism of your patient, so you cannot diagnose which kind of shock you're facing. So let's say now you've anticipated the situation that your patient would develop hypotension. So you've monitored him with an invasive pulse contour analysis device, so calibrated. Here is an example, is one hemodynamic device that is the PICO device. So now you will get all of these values, and I've already sorted them out for you. And then you could apply the same algorithm, but you have more precise measurements. You have direct measurement of cardiac index, of stroke volume, and of the resistance. And you have dynamic indicators of preload. So let's say, luckily, they are concordant with the basic monitoring. You have also, now you can also have a direct measurement of the inotropism, or indices that reflect your patient inotropism, and you can diagnose that your patient has cardiogenic shock. Now that you know what type of shock your patient has, you need to determine what caused the shock. And in the context of cardiogenic shock, you might use EKG or a morphological exam, such as TEO, to determine the cause of the hypotension in your patient and complete your diagnosis. So here is the conclusion. So when facing an hypotension in the operating room, first you need to eliminate the obvious and to apply pattern recognition in order to treat early the obvious causes. Second, if you're unable to make a fast diagnosis, you need to switch to an hypothetico-deductive reasoning. And what you need to keep in mind is that if your patient only have basic monitoring, you will only be able to diagnose the common causes of shock, which are hypovolemia and the distributive shock, and that the indices you would use are partly inaccurate. So you need to anticipate invasive monitoring in patients that are at high risk of developing perioperative hypotension. The third thing is to identify the unusual situation, and I think this is a situation of patients that do not respond to the initial treatment. And in this patient, you should consider additional monitoring in order to collect additional information and more accurate information about the hemodynamic status of your patient. And you should also consider a morphological evaluation, such as transesophageal echocardiography, especially if you're suspecting an obstructive or a cardiogenic cause of shock, and it might help you with the diagnosis. Last, you need to remember that beyond the type of shock, there is a cause for the hypotension, and you need to track that cause in order to treat your patients. I thank you for your attention.
Thank you, Dr. M.NGUYEN, for this lecture. Any comment? No. It was a great lecture, and I like the take-home message because in daily practice, physicians used to treat symptoms and to forget the cause of the symptom. And I think we have to keep in mind that hypotension and blood pressure is arterial hypotension is a symptom. There are causes that we have to search for, and effectively, in operating room, the most frequent cause is hypovolemia or preload dependence, but there are other causes that I think we have to treat. And the one other most frequent is perhaps excessive sedation with vasoplasia, and this is a very, very important message for me.
I think this is an important point because you looked at the preload dependency, which makes sense. So it can be real hypovolemia through bleeding, or it can be actually no change in blood volume, but a decrease in stress volume. And one of the most frequent and possibly avoidable is, of course, an excess of hypnosis. So in this sense, EEG-based depth of anesthesia monitors can be considered as hemodynamic monitors. And my opinion in 2022, beyond conflict of interest, is that whatever the patient, any general anesthesia going for longer than 30 minutes should actually benefit from depth of anesthesia EEG-based monitor because it's available, it's not very expensive. And now the newest technologies, which go beyond BIS 45 to 60 or whatsoever, allow us to detect with a lot of accuracy excessive depth of anesthesia. And this should be corrected because there's no possible benefit for this. But I agree fully with the rest of your presentation. Thank you.
Okay.